width. Okay, you know every bones with you correct anatomy. Okay. And we can divide bone fractures. The definition of fractures according to horizontal beams and vertical buttresses. And we have horizontal beams, superior orbital ribs and glabella, and it is H1, H1 there. Inferior orbital ribs and zygomatic arches, H2, and alveolar process of maxilla, H4. Indicates central and indicates lateral. Vertical buttress, frontal maxillary, frontal maxillary, and pterygomaxillary. Mid-face definition. This are the area between a superior plane drawn through the zygomatico-frontal suture to the base of the skull and inferior plane at the level of the maxillary dental occlusal surface. Structure connections, orbit, maxillary sinus, nasal bone, nasal orbital ethmoidal complex, zygomatic complex, and frontal bone and sinus. Area of trench is a vertical and horizontal collapse, muscular attachment, and area of the weakness, the architectures and lining tissues and air-fied cavities. Pattern of fractures of mid-face skeleton. We have alveolar fracture and dental fracture, Laprox fracture, nasal orbital ethmoid fracture, zygomatic complex and arch fracture, and frontal sinus and bone fracture. Mechanism: assaults, MBA, gunshot wounds, sports, falls, industrial accidents. Prevalence: the most common fracture type is zygomatico-maxillary complex. And then we have left root 1, left root 2, left root 3, zygomatic arch 10%, and 5% alveolar process of maxilla, smash fractures, and other. Evaluations: ABC, history, palpation of entire facial skeleton, occlusion, ophthalmologic exam consultation, C-spine, imaging CT, diagnosis, inspection, extraoral, for example, swelling, deformity, asymmetry, leaks, and intraoral, hematoma, occlusion, palpation, deformity, crepitations, thorax box count, and mobility. And then radiographical investigation. Radiology. Finding can include the following: occipitomental standard, 10 degrees, 15 degrees, and 12 degrees. Two lateral, soft tissue lateral, occlusal, intraoral, segmentovertex, CT scan, 3D CT scan, and MRI to detect CSC leaks and fistula. Radiographical examination, plain radiograph, occipitomental, and water view. Water view, 3 tables for isolated orbital fracture. But I think that this radiograph is history because we have CT or MRI. It is the best diagnosis to identify armor and bone structures. The line of Dolan and the elephant of waters. Lines of Dolan, they are foreign anatomic contours best seen on the water view of the face, and they were first popularized by Dolan. Three lines of Dolan lead the eye along some facially important structures. Second and third line together form the profile of an animal. We can also do lateral school view, OPG, ocular view of the maxilla, and periapical views of the mastiff. The best diagnosis to detect fracture of teeth. CT scan and 3D CT imaging, lower sections and axial sections. Whenever intracranial damage and frontal sinus are suspected, extensive fracture that involves nasal-ethmoid complex or orbital region, orbital trauma to evaluate the degree of orbital injury, and anatomus. Okay, now Leffler classifications of maxillary fractures. It was combined from one level examination for 1901 in Canada stars. Level A1, 2, and 3. On the picture, we have the line, systemic line, where we have fractures left foot 1, left foot 2, and left foot 3. And the next schema, left foot 1 is low level fracture. This is a relatively horizontal fracture in the body of the maxilla that results in maxillary tooth bearing fragment being detached from the middle face. The fracture line passes above the teeth, below the zygomatic process through the maxillary sinuses, the tuberosities to the inferior portion of the temporal plate. It can be unilateral or bilateral. And the next cannot go left one. Lateral bone with it. But the main mass of the face is the fourth one is also named as low level or Guerian fracture. It can have unilateral or bilateral. Horizontal fracture to the maxilla above the level of the nasal tube and alveolar process. Signs and symptoms. Light swelling of upper lip, ecchymosis in upper lip sulcus, hematoma intraorally over stoma and in right, distal occlusion, mobility of teeth of the involved segment of maxilla, combination of soft tissue laceration, exposure of nerve and the maxillary artery in case of throat injury. Impacted type of fracture is often not mobile and teeth straps may be damaged. Cracks for perfusion of upper teeth. And level 2 is named as pyramidal fracture. In this fracture, the maxilla will be separated from the base of the skull by fractures of the nasal bone and the frontal focus of maxilla. The fracture extends laterally through the lacrimal bones, roots of the orbit, and inferiorly through the zygomatic maxillary sutures, then pass posteriorly along the lateral wall of the maxilla, across the pterygomaxillary fossa, and through the pterygoid plates. And we have schematic of the level 2. We have separation of nasophageal suture, medial orbital walls from the lacrimal bone, and inferior orbital floor and ring, adjacent to infraorbital canal and foramen, anterior maxilla below zygomatic buttress and pterygoid laminae about halfway up. Separation of the floor from the base of skull is conducted via the nasal septum and may involve the floor of the anterior cranial fossa. And level 3 is a craniofacial dysfunction. Is the most complication injury. The fracture line passes the nasal bones and frontal processes of maxilla or nasofrontal and frontomaxillary sutures across the floor of the orbit through the ethmoid and sphenoid sinuses and the zygomatic frontal sutures. It passes across both pterygoid plates where they arise from the sphenoid bone, so it separates the middle third from the cranium. This is schema method 3. Separation of nasophageal structure, medial orbital wall, involves the depth of the ethmoid bone and quadriform plane, part below optic foramen and through the inferior orbital tissue, inferior orbital floor, lateral orbital wall, zygomatico-facial suture, zygomatic arch, and suprazygomatic root of pterygoid plate. Signs and symptoms, although it is possible to distinguish between levels 2 and 3, the signs and symptoms are almost similar. Gross edema of soft tissue, bilateral circumorbital ectinosis, bilateral subconjunctival hemorrhage, confused deformity of the nose, nasal bleeding and obstruction, CSF weak rhinorrhea, dish face deformity, limitation of ocular movement, possible diplopia and anatomus, lateral position of maxilla with anterior open bite, lengthening of the face, difficulty in mouth opening, mobility of the upper jaw, occasional hematoma of the plate, blackspot signs on reproduction, self-deformity at infraorbital margin, anesthesia of midface, nasal bone moved with midface as a wall, and tenderness and separation at partial zygomatic suture, tenderness and deformity of zygomatic arch, and depression of ocular level and pseudoptosis. We also have modifying lack of classification of the mid-face fractures. Left 1, low maxillary fracture. Left 1A, low maxillary fracture but with multiple segments. Left 2, pyramidal fracture. Left 2A, pyramidal and nasal fracture. Left 2B, pyramidal and Norway fracture. Left 3, craniofacial disjunction. Left 3A, craniofacial disjunction and nasal fracture. And level 3B, craniofacial disjunction and nasal ethmoid fracture. Level 4, level 2 or 3 and cranium-based fracture. Level 4A, supraorbital beam fracture. Level 4B, anterior cranial fossa and supraorbital beam fracture. And level 4C, anterior cranial fossa and orbital wall fracture. The common fracture classification: 1. A non-displaced, 2. Displaced, 3. Conminute or orbital wall fracture, 5. Rheumatic arch fracture. Frontal sinus fracture classification: 1. Anterior wall fracture, 2. Posterior wall fracture, 3. Anterior and posterior wall fracture, and frontal sinus fracture involving frontal apparatus. Indication for treatment: physical signs of a fracture of the maxilla, evidence of the fractured maxilla on imaging, disruption of the occlusion of the teeth, displacement of the maxilla, post-traumatic facial deformity. Fracture for displaced teeth, cerebrospinal fluid leak, abnormal eye movement or restriction of eye movement, occlusion of the nasolacrimal duct, sensory or motor deficit, other evidence of loss of function. Aims of treatment: the first, relieve pain, restore function, restore bone anatomy, prevent infection, restore the dental occlusion, restore jaw movement and the earliest possible stage, restore normal nerve function. Association with multiple injuries, presence of uncontrolled hemorrhage, impairment of the air, presence of bone comminution, association with a dual tooth, association with the base of skull fracture. Presence of existing dentofacial deformity, time elapsed since the injury, presence of a medical or surgical factor which would delay general anesthesia, presence of any factor which would delay healing, for example, nutritional deficiency or alcoholism, stage of dental development, deciduous, mixed, or permanent dentition, factors affecting the risk, presence of fracture teeth, total absence of teeth and tooth, inability of the patient to cooperate with treatment, association with fractures of the mandible, especially bilateral fractures of the condyle. Teeth and alveolar fracture injury which is limited to the teeth and supporting some structures of the alveolus. Boys are 3 times more at risk than girls. Causes: traffic accidents, falls during epileptic seizures, stroke injuries. We have to know about the history, personal history, medical history, previous dental history, history of trauma, when, how, where. Trauma history. When did the accident occur? The shorter the time between accident and treatment, the better prognosis. Where did the accident occur? If the accidents occur in the place, prophylactic treatment is indicated. How did the injury occur? Direct force under the chin from the fracture, direct force to teeth, crown fracture, root fracture, or display. Clinical examination, extraoral examination, Laceration, abrasion, contusion on the head and neck can be noted visually. Any asymmetries, including deviation in the opening. Intraoral examination, soft tissue, tone, umbilical, displacement, mobility, fracture, color change. Vitality test, just following traumatic injury often given false negative response. Types of vitality test, thermal pulse test, electrical pulse test, and cavity test. Treatment, soft tissue injuries. Determination of child's immunization status if the child had received a primary immunization activated with booster injection peptide. An immunized child can be protected by tetanus antitoxin. Adequate debridement of the wound. Radiographic examination. State of wound formation. Prevalence of wound fracture. Periapical radiolucentis. Injury of the supporting periodontal membrane. Degree of intrusion or extrusion of the tooth. And size of the pulp. If a jaw fracture is suspected, extraoral radiograph indicated panoramic and lateral oblique. List application. List class 1, enamel fracture. This level of injury includes crown fracture that extend to the enamel only. These teeth are usually non-tender and without visible color change but have root edges. List class 2, enamel and dentin fracture without pulp exposure. Injuries in this category are fractures that involve the enamel as well as the dentin layer. These teeth are typically tender to the touch and to air exposure. A yellow layer of dentin may be visible on examination. List class 3, bone fracture with pulp exposure. This fracture involves the enamel, dentin, and pulp layer. These teeth are tender, similar to those in this early two category, and have a visible area of pink, red, or even black at the center of the tooth. List class 4, traumatic tooth that have become non-vital with or without loss of tooth structure. List class 4, luxation. The effect on the tooth that tends to dislocate the tooth from the alveolus. Teeth loss due to trauma. List class 6, avulsion. The complete separation of the tooth from its alveolus by traumatic injury, fracture of root with or without loss of crown structure. List class 7, displacement of the tooth without the fracture of crown or root. List class 8, fracture of the crown and mass and its tooth placement. List class 9, fracture of the tooth. Class 1, a crack of the enamel without loss of tooth structure. Units do not require immediate treatment. And fracture of enamel only smoothing the sharp edge, regular perimeter, and radiograph. Class 2, immediate treatment of the crown is required to protect the pulp, restore the aesthetics and function, cover the exposure of the dentin by a layer of calcium hydroxide to regulate the dentin formation, reattachment of two fragments, acid edge compromised enzyme restoration. Lastly, the treatment depends on many factors such as vitality of the exposed part, like the exposure, time elapsed since the exposure, degree of maturation, restorability of the fractured skin. The main objective of treatment is to maintain the vitality of the tooth. Amplification is a process of promoting apical closure of the root in endodontically treated tooth by displacement of calcium hydroxide based or other tissue tolerant material in the root canal after an apical stone. Ampersogenesis, it is a physiological process of development in the vital infected or traumatized stimulation to make the end of the tooth root growth in the traumatized tooth with classical treatment usually involve removing the root fragment. It can be extruded orthodontically or crown surgery to gain access to the to placement restoration. Horizontal root fracture, when this fracture occurs near the apical one to point that surface is not favorable, then lies in the middle of the apical boundary because more alveolar support. Immobilization of the tooth is much easier. Treatment of root fracture depends on the condition of the bird and amount of mobility available for the fracture bone. Apical 1, 2, 3 root fracture, reduction, cleansing the tooth, and the tooth should be checked periodically for vitality and fracture. Middle 1 to 3 root fracture, reduction, cleansing the tooth. The patient retired in 2 months, check the vitality, fracture. In the treatment vital and there is no healing process of the following treatment is performed. Exit of both fragments, apical fragments removed surgically, intraradical pin to stabilize segments. Apical 1, 2, 3 root fracture, reducing, slinging the tooth, regard the patient periodically, check the vitality and vertical. If there is revolution and fragile closing, the following treatment is performed. Extraction of the tooth, remove the apical fragment, and the osseous implant. Orthodontic extrusion, if the fracture is 1 to millimeters in one bone, the coronal segment and osteoclast to extract the tooth. The apical root fracture, usually the prognosis is not very favorable. Treatment is extraction of the tooth. Conclusion, a mild blow to the tooth resulting in mild sensitivity requires little or no treatment. Need only regular vitality test. Simple session, mobility of the tooth without displacement. Tooth may be sensitive to percussion. Mobility is can explain the tooth using the acid edge printing technique. Regular vitality test and radiography. Displacement of anterior teeth. Lateral fixation, intrusive fixation, extrusive fixation, and fusion. Lateral fixation, displacement of the tooth in any direction other than the actual one. If the patient comes immediately after trauma, reposition thinking. Once the tooth has solidified in its position, orthodontic treatment is required. Intrusion, displacement of tooth into the socket, primary tooth, with every graft over a period of few months. If the intruded tooth is in contact with underlying permanent tooth, should be removed. Permanent tooth, immediate surgical reposition, painting, orthodontic extrusion, and the tooth with incomplete traumatic tooth may erect continuously. Extrusion, partial displacement of the tooth out of the socket. Primary tooth, usually extraction. Permanent tooth, reposition and planting. If the vitality of tooth is lost, start with treatment immediately. Placing calcium hydroxide in the canal for thick retinol followed by commencing convolution, complete displacement of the tooth from the socket. There are two important factors to be considered in case of occlusion: time between the injury and treatment, and conditions under which the tooth has been disturbed. The tooth must be kept moist to prevent damage to the fibers of the I'm sorry. In any case, the initial patient contact is by phone. The tooth should be handled by the crown. The tooth should be placed in dilute storage medium, milk, amphotic water, blend solution, or in backward by or under the tongue. At the dental office, information about the channels of irrigation should be obtained. Replantation, planting for 7 days, but immature apics 3 to 4 weeks. Calcium hydroxide should be replaced. Exit. Duration of immobilization, mobile tooth, 7-10 days. Tooth displacement, 2 to 3 weeks. Root fracture, 2 to 4 months. Implanted tooth major, 7-10 days. Replace tooth in major, 2 to 4 weeks. Alveolar bone fracture involve block of alveolar bone with or without intrusion of teeth, extrusion of teeth, fixation of teeth, and fracture. Alveolar fracture through the alveolar process. There may be concomitant injuries, crown, root fracture, and soft tissue, which may reduction, splinting. Types of splinting: edge composite splinting, interdental wire, vacuum flow plastic splint, arc-beared splint, more rigid and the longer stabilization, the more with resorption, ankylosis that can be expected. Termination periods for dental injury, blow out fracture, orbital fluid fracture. The usual mechanism is a blow to the eye, with the profit being transmitted by the soft tissue of the orbital wall to the thin floor of the eye. The fluid is usually the part that leads to a return from fracture downward into the macular smooth. Common clinical signs are penophthalmos and diplopia. 24% of these fractures are associated with ocular injury. On a water views, meaning one may see a soft tissue mass and the value of nothing in the maximum sinus, representing the herniated periorbital tissues in the dictionaries. One may also see a structural fragment of bone protruding down into the sinus, often hanging in the mollinal side. Periorbital tissue syndrome, retrointubular syndrome, a neurological disorder that results if the superior orbital fissure structure, mainly to diplopia, paralysis of extraocular motions, and rectangles and ptosis. A number of important anatomical structures pass through the fissure, and this can be damaged in orbital trauma, particularly blowout fractures through the floor of the orbit into the maxillary sinus. The structures are superior and inferior divisions of oculomotor nerve, trochlear nerve, lacunar frontal and lateral ciliary branches of ophthalmic, and Dussen's nerve, superior and inferior division and ophthalmic brain. Inferior division also passes through the inferior orbital fissure, empathetic fibers from cavernous plexus. These include non-visual sensory messages such as pain or motor nerves. They also serve as a vascular connection. Orbital apex syndrome, superior orbital fissure syndrome, BN2, involved. Blindness or loss of vision indicates involvement of the orbital apex, which is more serious, requiring other surgical intervention. Mandible fractures. Mandibular nerve through the foramen ovals, inferior alveolar nerve through the mandibular foramen, inferior dental plexus, mental nerve through the mental foramen. Blood supply, internal maxillary artery from the external carotid, inferior alveolar artery through the mandibular foramen, mental artery through the mental foramen, Gilman and Knapwick's classification by anatomic region, Timsey fracture, midline fracture, canine legend fracture, body of the mandible between canine and angle, angular region, triangular region bounded by the anterior border of the masseter to the posterior superior attachment of the masseter, ramus region bounded by the superior aspect of the alveolus line stopping and apex and the sigmoid notch, coronite region, condylar fracture, dental-alveolar region. Types of fracture: simple, basic fracture, rare, usually in children, fracture with non-displacement, fracture with non-displacement, minute fracture, extensive wreckage with possible bone and soft tissue loss, bone fracture, severe and tooth-bearing ulnar fracture, and pathological fracture, osteomyelitis, neuropathy, and generalized collateral disease. Types of fractures: condyle fracture, intracapsular fracture, extracapsular fracture, high condyle neck fracture, and low condylar fracture, angle thoracic fracture, body fracture, canine region, trachyphalangeal fracture, midline fracture, and coronary fracture. Frequency by location, you can see medical history. Bone disease, neoplasia, arthritis, DMD, risk for ankylosing, collateral vascular disease, endocrine disease, nutrition and metabolic disorders, including alcohol abuse. We have fracture nerve, and physical examination, change in occlusion, determine brain injury occlusion, posterior premature dental contact or an anterior open bite is suggestive of bilateral condylar or angle fractures. I'm sorry. Posterior open bite is common with anterior alveolar forces or present disease fractures. Unilateral open bite is suggestive of ipsilateral angle and parasynclinal fracture. Retrognatic occlusion is seen with condylar or angle fractures. Condylar neck fractures are associated with open bite on upper right side and deviation of chin toward the side of the fracture. Critical examination, anesthesia of the lower lip, abnormal mandibular movement, unable to open, coronary fracture, unable to close, fracture of alveolus and group of flatness, treatments. Laceration hematoma extremities, positive. Factors influence the site of fracture and displacement, anatomy of the mandible and attached muscle, hanging and weakness, weakening areas of mandible, resorption and pathology, direction of force of the blow, and age of the patient. Favorable or unfavorable. Mandible fractures are favorable when muscles tend to draw bony fragments together, and unfavorable when bony fragments are displaced by muscle forces. Favorable fractures line and the reduced fragment with the side. Effect of muscles on displacement. Transverse median fracture continuum results by the action of myofascial and geniohyoid. Oblique fracture parasymphysia tends to overlap under the influence of muscle section. Bilateral parasymphysial fracture results in backward displacement associated with loss of branch control when the level of consciousness is depressed. Bilateral parasymphysis fracture results in backward displacement. Body fractures often are unavoidable because of the actions of the muscle temporalis and medial muscles. We disrupt the proximal segment superior medically. Additionally, the myofascial muscle and anterior belly of the digestive muscle may contribute to the unavoidable nature of this fracture by displacing the fracture segment posteriorly and inferiorly. Vertically unavoidable fractures allow distraction of fracture segments in an horizontal direction. Horizontally unfavorable fractures allow displacement of segments in the vertical plane. Condylar fractures, the most common mandibular fracture, unilateral or bilateral, intracapsular or extracapsular, Intermedial placement is common, but it may remain angulated with the rivals. Dislocation of the splenoid fossa and fracture of the throat temporal bone, which is really rare. With the three types of condylar fractures. Signs and symptoms: swelling, pain, tenderness, and diffuse of movements, deviations of mandible toward the site of fracture, gradient of occlusional premature contact on the posterior tip with bilateral condylar display or overriding fractures, and displacement of mandible toward the affected site, anterior open wide and opposite sides of fracture, laceration, retroauricular ecchymosis, cerebrospinal leak, and atrophia in association with skull-based fracture. Sequelae of TMJ injury, arthritic changes, anarthropathies, fibrosis, and ankylosis, and today, Staphylococcus infection with condylar backward displacement and external auditory meatus injury, meningitis with retrotemporal bone fracture and intracranial involvement, Coronary process fracture, navale fracture caused by down antibody synthesis and the result from the contraction of the device. And the follows can be seen following operation of large ramesis, acid tenderness over the anterior breastbone. Fracture of varus of mandible, type 1 single fraction. Imixlow condylar fracture and that one below the sigmoid node. Type 2 comminuted fracture. Common is mesial injuries and appear to lead to displacement due to effects of masseter and medial cervicoid muscle. Fractures of the angle and body, clinical symptoms: pain, tenderness, and twistness. Extraoral swelling and the angle without ovule deformity, stem deformity behind the molar-teeth, movement and crepitus at the fracture site, an arrangement of occlusion, intraoral, local, and lingual hematoma, involvement of inferior genito-alveolar nerve, gingival tear if fracture in detented area, tooth involvement, and longitudinal tooth fracture. Inclined fracture of the mandible, the most common is fracture, always spine crack, and bicipital or parasitial fracture, commonly associated with condyle fractures. Unilateral fractures lead to overriding of the firmness, and bilateral may contribute in loss of lunge control. Lunge can include represent a weak area and contributes to parasitial fracture, rarely runs across mental plane, in line fracture of the mandible, pain and tenderness. Meaning and ulna, development of stem deformity, mental anesthesia, paresthesia, hematoma in the pool of mouth and background organ, soft tissue injury of the chin and lower lip. When associated with condylar fracture, absence of condyle movement in the consolateral side, deviation of mandible, anterior open wide, guarding of occlusion, limitation of the opening. Brain radiograph, OPG lateral oblique. PIA mandible, upper mandible, lower of liver, CT scan, 3D imaging, and MRI. General principles of treatment: control of bleeding, control of infection, tetanus, nutrition. Almost all can be considered with fixation and they communicate with skin or oral cavity. Reduction of fragments in good position and fixation, immobilization antibody panels occlused, oral care, regular so follow-ups to be by with the active factor occlusion rate. Treatment option: no treatment. Stop diet, maxillomandibular fixation, close reduction and immobilization, open reduction and rigid fixation, open reduction and non-rigid fixation, abdominal fixed pin fixation, and flat screw. Sedentary station, dentures, pain, colon-zygomatics, and colon-mandibular fixation. Definitive treatment, soft tissue retraction, debridement, irrigation with saline and antibiotics, closure in layers, jointings, reduction and fixation of the jaw, loss reduction and left traditional Latin means of manipulation, open reduction and semi-rigid fixation within the self-violence, open reduction and rigid fixation, close reduction, arch bars, out sour common failure that common outliers. Comes into other planning code for the purpose of close reduction. Close reduction, bone brackets, near screws, dental wiring, diode wiring, eyelid wiring, local anesthesia station, minimal sedation, and toxicity. Gallantry or modality, attention patient will be fixated with not flexible, rectally fusion, and closed case. Open reduction and fixation, intraoral approach, extraoral oral approach, and submandibular approach. Rigid fixation, lights and screws, Victor Navile, black screws, condylar thread, intraoral approach, dynamic infusion, extraoral approach, clavicular approach, retromandibular approach. External fixation. Interosseous non-compression small plate, compression plate, mini plate, back screws, and resorbable plate flat screws. Osteosynthesis ideal line of osteosynthesis. The ideal line of osteosynthesis in the body region has the vertical side of tube upward pins from the cranial region to the orbit line. This line is located directly underneath the map for gingival circles, and it can be both with ease. The bone thickness from the lateral cortex varies between 6 and 8 millimeters approximately to avoid injury of the two roots. Gonocoptical screws less than 6 millimeters long should be used for plate fixation along this section of the ideal osteosynthesis line. A simple plate fixation method is contraindicated in the anterior mandibular bone because of the existing rotational process in the cranium that have to be neutralized. New plates should be applied to neutralize this process. In the posterior transition to the album and ramus, the second plate just below the oblique ridge may be advantageous in case of reduced bone stock, for example, intact pupil tooth, but significant fracture replacement. Fracture mandible in children, close reduction, open reduction and fixation, lighting at the inferior border and retrograde place. Education flow of the removal of teeth in the line of fracture. People say this for its so-called interval improves reduction of the fracture. Two this is fractures. Two with advanced and is coming and significant risk of access to treatment. Two with advanced redundant disease, its mobility which would not contribute to the establishment of stable cochlear. And two with resistant pathologies such as cyst formation and recurrences. Indication to leak teeth in the line of fracture. So that not interfere with reduction and fixation of fracture. In tooth removal requires removal of excessive amount of bone so as to compromise the fracture site and possible place screw fixation. Due to that is in good condition and process in condition for healing and reducing the fracture. Management of teeth retained in fracture line. Good quality in the oral periodical behavior. Incineration of appropriate systemic antibiotic therapy. Splinting of tooth if mobile, endodontic therapy is if part is exposed. Immediate extraction if fracture becomes infected. Follow up for 1 year and endodontic therapy is there is a lot of variability. Complication. Socioeconomic condition and greatly affect the outcome, infection, delayed healing, and non-union, not common cause in infection. The most common cause in non-compliance, inadequate reduction metabolic or nutritional definitions can play a role. Next, paresthesia, malfusion, and non-union, PNG problems. No statistically significant difference in complication rate between patients treated with new place versus LMF with biovaccine. With multiple techniques available, there is still controversy over the best treatment for each type of mandible fracture. The decision is a clinical one based on patient factors, the type of mandible fracture, and the skill of the surgeon and the enabling framework. Further studies are in progress. A non-union occurs when the mandible does not fill in an appropriate time. The result is mobility in the fracture segment whether after an adequate filling place. Etiology, fracture instability, infection, incomplete reduction, no contact between segments. And treatment, identifying the cause, controlling infection, surgical reconstruction, removing them with survival, debridement of capital bone and soft tissues, replication of bone fragments, and the fracture ends by establishing occlusion, stabilizing segments using unlocking reconstruction plate and autogenous bone graft is this area. Non-union on malocclusion, inadequate occlusion reduction during surgery, inadequate cells reduction during surgery, no cells reduction on purchase, lymphocyte application of internal fixation device, inadequate stability. Identification of the cause of the dentic of the pelvic treatment is possible. Osteotomy is necessary for the fracture standard osteotomy combination. Infection, diagnosis, swelling, erythema, with wound pain, purulent chest, microorganism, fracture instability, and digital tissue X, for example, teeth bone. Infection, incision and drainage of abscesses, education of the wounds necessary, systemic antibiotics, removal of the digital teeth bone, removal of any used internal fixation devices, restabilization of fracture. Antilogus is a touches where the mandibular converge into the granite fossa. They generally occurs after plural non-normalization of the condylar fracture. Fixation failure results in fracture mobility that can be subsequently lead to infection and women and fixation failed by a number of current which includes insufficient amount of fixation, fracture of the plate, loosening of the screws, utilization of bone around screws. Thank you for today.